Hello, hello, hello. Welcome back to another episode of the Red Pill versus the Blue Pill. It's your favorite Deprescribing Pharmacist, Dr. Delon Canterbury here, founder of GeriatRx, along with the Deprescribing Accelerator. It's an awesome, beautiful day. Here we are again in the world of Deprescribing paradise, and life is good. Can't complain. How are you all? Let me know in the comments. Would love to check in with my peeps who are tuning in. If you're live and feeling good about the year, just comment Red Pill. Let me know how you're feeling. But welcome back again. This is our weekly show. We have the Red Pill versus the Blue Pill. The Red Pill and the Blue Pill, as you know, comes from my favorite movie, The Matrix, where I believe our healthcare system is a matrix. And we all need to find a way to choose the red pill. The red pill being a metaphor for holistic healing, deprescribing, using true lifestyle medicine at its core and unearthing the model that just keeps us, frankly, sick. And we got to do better. It costs too much and it's not as effective as it can be. And I believe deprescribing is the red pill we all can advocate for, regardless of your clinical background, regardless of where you hail from or your practice. I believe we all have that ability to advocate for less is more, especially when it comes to our most vulnerable population, our older adults. So yes, welcome back. Welcome back. And speaking of older adults, we've got a huge industry in aging. All right, from people advocating for caregivers to patient navigators, of course, to senior living, to understanding elder care attorney, elder abuse, concierge providers, PT, OT, wellness, you name it. There are movers, people who are doing downsizing, people transitioning into different care facilities. There is a step across each and every path that requires a trained expert or professional to help you move along. And so my question to you today is, if you're dealing with a loved one or faced with, caregiving yourself, have you built your aging friendly roadmap? Do you have your team assembled like Marvel? Like, do you have the dream team of people that can help you figure out, estate planning or long-term care insurance, or, just general health and well-being? Do you have people in your corner? And I find in this space, most people do not know where to start. And don't get me wrong, this stuff is not easy. It's not easy. There isn't always a quick little cheat sheet that tells you where to go for all of these resources. And frankly, a lot of us are doing things usually in a state of crisis. Usually there's an incident or a fall or something that's leading to you to go down this road of, okay, where do I go to get help? And no one wants to make emotional, life-changing decisions while in crisis mode. So I always encourage my clients to have that team built, before you are faced with having to make those decisions on the fly, because this stuff ain't easy. There isn't a magic wand out there. And I feel like in ways, part of this is deliberate because, when you're making decisions in crisis and emotionally, you're likely to make a mistake and you're likely to do something that may cost you more in the long run. Because we didn't have the wherewithal to plan when things were cool or copacetic. And it's a shame. It's a shame. And it's no one's really fault. It's just, I think, especially me, as I'm starting to hit, middle age and enter my 40s in a few years, it has everyone wondering, is mom and dad okay? Like, are they going to be fine? When it comes to, it's a real thought on my mind. I'm sure most of you who are dealing with either entering, parenthood and now, wondering if, mom, dad, your grandparents are still around, if they're going to be fine when it comes to aging and in the most, healthy and perfect conditions that you can possibly afford. Um, and we don't always know that, and so it's awkward to have those financial conversations, or, dad, what do you want the end of life to look like for you? Like, where do you want to be? Do you even want to be buried? Like, what do you want? Do you want to be, have your dust sprinkled in the ocean? Do you want an archery death where you're burning in a pike in the middle of a lake? Who knows? But have you had those convos? And is that somewhere on paper? Is there a legal document? Is there a will? Have you discussed those advanced directives, right? And for those of you, who middle class, worked all your life, you're dipping into your retirement in older age, because you're not working anymore. Like, what are you doing to survive? And is there a plan for that? And especially when we're talking about communities of color who may not really always have the reserves, which we know historically don't have the same assets as our white counterparts. There's going to be less in the bank saved, and so a lot of us tend to just go to the multi-generational approach and just say, all right, we'll just move mom and dad in and we'll do it all ourselves because it's our duty. And now you're raising them again, your parents or your in-laws, or even a distant aunt or relative, while raising your kids, and that's what I feel a lot of us may do. And you end up now burning at two ends of the candlestick, and now you're exhausted. And now guess what? You become one of those patients in 20 years with chronic conditions and, maybe even memory loss, whatever, because of the blight of, and I would say sometimes it's also a gift, but I'm not going to say there is a burden when you become a caregiver. There is a burden. And you have to be aware of that and how you're planning for your peace, and at least try to make a plan for yourself and for your loved ones before it gets to that stage where they can't tell you what's wrong or they can't tell you what they would want. And that goes for you too. So we take that on, easily. I mean, we do it with pride, and we think it's a duty. And caregivers are, of course, underpaid, undervalued, save our health system, over $800 million a year in unpaid labor. We do it all. We do the care coordination, do the care planning. So if I were to ask and pose a question to all the caregivers that are out there who manage the meds, who do the appointments, who do the booking, who drive them, who take off of work, who are just faced with this duty, how many of you have had someone literally sift through every single med or herbal or supplement that your loved one's taking? And how many of you have done that to the extent to make sure that what they're taking isn't causing any type of issue in their care? Especially when we're dealing with those with cognitive impairment. And there may be some administrative barriers in taking a pill or giving them a med. It's not always easy to self-administer when you not realize you're supposed to. So have we made sure that if they are on a bunch of meds, or the amount of meds that they're on, is it truly the appropriate number? Is it truly safe? Is it best for them now? And I would love to know in the chat if you've experienced that. I would love to know where and what setting that was done. Was it your local pharmacy? Was it at an annual visit? Was it a family friend who's a clinician and happened to kind of have their brain picked and you told them what was going on? But I guess I see it as, why, if you haven't experienced that, why? And if you haven't experienced that, was this ever a thought that came up that could be a problem or could be a concern? And of course, we know drugs can be expensive. Sometimes there's a cost. So yeah, I know some people, just paying for meds is annoying, right? If you're paying too much, when was the last time you've had that convo with a clinician or pharmacist or whoever? to look for a substitution for you or discounted rate or cheaper option, I'd love to know just where would you go for that information. So I'm posing these hypotheticals, again, kind of painting the landscape of what a caregiver will have to navigate. We're all caregivers if you don't realize it, or you will be. But these are things you're going to have to weigh. And a lot of why I started this company, GeriatRx, was focusing on helping caregivers at least take this one aspect off your plate, right? And I'm going to make sure those meds are at least what you may need. The best is my ability. And I found that although that was what the bedrock of our company was, we found ourselves doing all tons of other stuff. We found ourselves referring to people who may need a physical therapist, or someone who needs a speech therapist, or someone who actually needs help with financial planning or finding a place for mom, a place to live, you know? And so being in this space afforded us the blessing to work with other aging service providers, which is dope, because guess what? I don't know all this stuff. I'm not supposed to. But what I do know are that there are these awesome people called care managers, geriatric care managers, or aging life care professionals. Some are nurses, some are social workers, some are, some are gerontologists. Some of them frankly, they all just have the passion for aging. They all have a passion for older adults. And so what ends up happening is that these people know the ins and outs of this elder maze, okay? And knowing who's kind of reputable for this, who's reputable for that. And they are just brilliant. And when they can navigate, hey, what do you need? Especially better than me, I'm saying, boom, you need to talk to such and such. They understand who to set you up with. And yeah, we have our resources. But my point is, when you have someone advocating for you, because if you don't know what you don't know, some people may have a law misinterpreted, and now you are downsizing your home in hopes of getting Medicaid without realizing Medicaid has a 2-year look back or 5-year look back on your finances. So you would have sold all those things and still not qualify. So it's just knowing some of these little loopholes, I call them, in aging, are exactly why you need someone like a care manager on your team. But more importantly, it's why you gotta have a roster of people in the aging industry to help you navigate. Because I damn sure promise you, no caregiver just has a loved one change and decline, and now you know where to go for everything. No one knows this stuff unless you're faced with it, you're doing it, and you gotta just have the experience. And so what I envision, and Giles, appreciate your comment, man. Giles, I'll share with those who may not have seen, but Giles was mentioning how he had to speak up when his father had 20 plus meds at a time. He was kind enough to have a Walgreens pharmacist research the meds, look at all the interactions, look at all the duplications, and then he created a Deprescribing plan, it sounds like. In fact, Giles offered to pay him for that. Now, as a Walgreens pharmacist, so Giles, you may not notice, I used to be a Walgreens pharmacist. That is an awesome story. I love hearing our community frontline people making these type of valuable, life-saving interventions. So kudos to that Walgreens pharmacist, and kudos to Giles, really, for you as a caregiver, knowing when to ask and investigate what happened there. And Giles was kind enough to offer him to pay. But the pharmacist said, it's a pleasure. And yeah, there's no way you can just pay a pharmacist directly when they're on the clock for Walgreens, which, hey, I get it. So I'm glad you had that positive experience, man. And I feel when I was in that setting, as much as I wanted to do that, and there were times I did, I could not do that to the best of my ability at all times. All right. And that's where I realized when majority of my older adult patients, were in a rural setting, didn't have that many providers. There really wasn't like a town geriatrician because I was in a pretty remote area. And, I realized like, yo, I'm one of two pharmacies here. I am kind of the last resort when it comes to the pill going into your mouth in terms of it being safe, appropriate, and effective for you. And that was the reality check that got me into geriatric medicine, because guess what? I didn't know what the hell I was reviewing when it comes to older adults. I knew as a general pharmacist, hey, yeah, this matches, this is good. But I wasn't thinking like a geriatric pharmacist or a deprescribing specialist, right? Because you start seeing more and more older adults have one of the highest pill burdens in our populations. So using that kind of model, Giles, go back to your example, that's what geriatrics is. You essentially can pay us flat fee or an ongoing 6-month package for us to implement, monitor, and advocate for deprescribing with your care team, with your providers, and with your family. That's what we do. That's what we live for. But to that same point, it took Giles having to make that step. If Giles did not go to someone and ask, hey man, can you take a better look at these 20 meds just to make sure? Because let's be honest, when you're in that zone, sometimes you're just seeing one or two, to verify for that patient. You're not filling all 20 meds at once. Sometimes you are. But for the most part, you're not really thinking and sitting with the full picture when you've only got a minute to 2 minutes to really check each script and keep going about your day in that setting. So that's where seeing it firsthand in the community was an amazing blessing. Walgreens taught me so much in talking to people and problem solving quickly, getting real creative, doing some mental gymnastics with the clinical health system. Worst part was maybe seeing drug prices for eye drops just completely decimate people's funds because they're in a donut hole. I mean, thankfully we don't have that as much now, but in those days it was rough telling someone to pay $500 for an eye drop because you haven't met your deductible. It was tough doing that. And it's like, damn, why are we punishing Medicare recipients? They've already put in their blood, sweat, and tears into the country's health and taxes and all the stuff. And now I have to be the guy to say, here's the copay and sorry, try to make a change. But no, you can't because it's a brand name. And anyway, we're not going down that rabbit hole. My point is, in seeing patients like Giles or loved ones on all these meds, it got me realizing I didn't know what I was doing clinically to deprescribe. And of course, when you're in that setting, you're not paid to deprescribe. You're paid to fill. You're paid to dispense and make sure it's, quote unquote, safe. And I felt there was a deeper disservice I was doing because I couldn't fully give people the option in some instances to shave their med list in half, right? If they're on 20 or more. So that dawned on me that, you know what? Everybody needs a pharmacist, and everybody needs, especially when you've got older loved ones, someone who understands aging in geriatric medicine. Because we don't have enough geriatricians, we don't have enough geriatric PAs, we don't have enough geriatric nurses, we don't have enough geriatric caregivers who are paid to caregive. So who is the one doing the med management? Like, who's actually looking to see if this is age appropriate and necessary and vital? And it should be pharmacists. It should be. Doesn't have to always be, but if you want someone managing the drugs in an older adult, you want someone who understands drugs and you want someone who understands aging. And realizing there aren't many deprescribing specialists in the community, unless we're talking to one of those awesome docs who just loves holistic stuff and they make that the bedrock of their care. Awesome, great. I want that. Trust me, I do. Why don't we have that across the entire continuum of aging? Yeah. Why don't we have that across the entire spectrum, from transitions of care to annual wellness visits to cognitive assessments to every specialist who sees an older adult, to going to your physical therapist, to your speech therapist, to your occupational therapist, to your dental office? I mean, why isn't there a systemic, and there are many, it's a loaded question. There's many reasons why not. But if we know for fact this is the most over-medicated group in the world, older adults, why isn't there a paradigm where everyone gets a quarterly, biannually deprescribing consult, where there are thousands of touch points within the aging industry, from caregiver support groups to dementia nonprofits to nutritionists, dietitians? I mean, everyone's seeing an eye doctor, everyone's seeing, a cardiologist, everyone's seeing all these different people, but systemically, we don't have that champion for deprescribing. We don't. The aging industry does not have that. Now, geriatricians by nature, they love that. They do that. They're awesome at that. Functional med experts, they do that. Holistic healers, they do that. Those functional health conscious pillars of lifestyle medicine people all do that. People who understand integrative medicine, they do that. Most of those people I named are not covered by insurance. Why is that? That's weird. It's weird to me. It's weird to me. So that's what's missing. That to me is what's missing in this aging industry, where the touch points can all pose questions. You don't have to be clinical pharmacist to have these discussions. You can be someone who literally looks at a list and may have an idea of which ones are deemed not the best ones or not the most safe ones for older adults. Or just simply ask, hey, man, how long have you been on all this stuff? When was the last time you had someone actually work with you to see about tapering or stopping one or two? And again, this is just a philosophy. This doesn't have to be as hard as we make it out to be. But that's what the aging industry wants. That's what the people want. The people, nobody volunteers and say, yes, sir, I would love to take 23 meds today, twice a day, before I go to bed. I love that. No one's saying that. Nobody enjoys that. So use this opportunity to give what the people want. This is what the people want. This is what, frankly, clinicians want. Doctors don't want people on a bunch of meds. It's more stuff to manage. It's more liability. They don't want that either. Insurers don't want that. They don't want to pay for drugs that are going to make you more sick, and now you end up back in the hospital that they have to pay. Nobody wants that. Okay, so insurers don't want that. Big Pharma may want it. I don't know. Probably. I mean, whatever. It's a script. PBMs may. I don't know. The point is, nobody wants people sick, truthfully, but the system does. And the system thrives on that cyclical in and out, in and out, in and out. Because that's a copay. But the family who we all got into this industry for doesn't want that. The caregiver doesn't want that. So let's just give them what the people want. And so when I go and do conferences and speak and meet people and learn about their stories and journeys and navigating meds, just like Giles earlier, who was able to get a plan to deprescribe and manage which ones to get rid of or keep. I hear that from caregivers who are just concerned and fed up. They didn't even talk to a pharmacist. They just went and said, this is not happening anymore. We need to change something. Here's what I'm seeing. They led with the harm that they have seen, right? They're not just stopping things cold turkey, but they said, hey, this is the problem here. We have to stop something? Can you do something? Most doctors want to do that. Most doctors want to do that. Like, people care about their patients. We're not soulless. This isn't a blame game. We just want the best outcomes for people. So when you bring it to them with this concern and with some, little bit of why, most are going to say, yeah, let's do something about it. So I don't want caregivers to feel afraid to have a frank conversation that, one, it's your health. Have all of the frank combos you need to have. Like, it's you or your loved one's health. So don't get mired into the politics of it. Just have a talk. If you have that ability. Not everyone has that ability. Not everyone has that voice in all care settings. Not everyone has an advocate. Not everyone has, a patient navigator. Not everyone has a deprescribing specialist that they can call and say, here's why we're seeing some issues. Not everyone's doing that. So to me, that's the missing link in all of aging. And don't get me wrong, we've got brilliant, phenomenal consultant pharmacists who are doing their damnness within long-term care pharmacies and settings. They're doing their audits. They're doing their compliance and reg checks. They're doing their med pass crash charts. They're doing their gradual dose reductions. I love it. We're not knocking consultant pharmacists. We're knocking this system where we've got 1% to 2% of seniors that even live in those settings, compared to the other 55 million that are in the community, and all they get is a hopeful checkoff list at the doctor's office, or maybe an MTM call from their pharmacy that they ignore because they don't really have empathy with the patient. They don't really have that bond to have that discussion. So we're not doing it. We're not doing it systemically. And so why not start in the centers and places, whether it be an adult daycare or a senior center or, some area agency on aging or some older focused conference, leading age or whatever. Why not have those convos where people need to hear it the most? And it's usually the person in front of you, the patient. It's usually the patient. Start there. Start where they meet up. Start with the bridge club. Start with the church group. Just start. Just talk about it. Just talk about it. And so people want this. What have they tried? Some of the doubts are, well, this isn't my responsibility. So we're going to pass the buck on that. You need to talk to your doc. Sorry. I mean, we all know they need to talk to their doctor. Does that always work? Half the time, the patient's going to forget to talk to their doctor about that. The other half, there might be some other issue that comes up because really you're just trying to put out the immediate top 3 issues that are going on with you for the day. You're seldom thinking about the meds unless you have been coached and guided to talk about, here's where my issues are. Because guess what? We all believe the meds are safe. We all believe it's helping us live forever. And in instances, yes, they are. But we don't always challenge if it's still appropriate and necessary at present for especially your grandmas and grandpas out there. So what have they tried systemically? Well, we've got LTC pharmacists, we got consultant pharmacists. They make all these recommendations. They find all the things that can be tweaked or fixed. They fax the recommendations, and then it falls short. And then the provider acknowledges and ignores their recommendations. So it's like, all right, that's my 1 month. Okay. Now you've got some that are like, oh yeah, my pharmacist said this. Boom, let's change everything. Dope. Patient gets better, great. A lot of the times, it's not like that. A lot of times, you got one person, one pharmacist who's managing 6 to 8 nursing homes with 30 to 100 beds each, billed or paid $7 to $8 a bed to review 20 plus meds per person per nursing home. You really expect that they're going to give the warm, fuzzy, quality, strongest review where a high percentage of it will be ignored, or a high percentage of it, as much effort goes into it, falls on deaf ears, or just sits and we'll just readjust next time, or you just repeat. So after a while, you just end up fed up. You end up just trying everything that you can, and you're just hoping. It's like, damn, we're hoping our best clinical judgment is received when we literally are trained in drug pharmacology. Like, damn, that's the bedrock of our care. That's awesome. And this, mind you, in a skilled nursing facility setting. This is not all ALF settings or retirement settings. This is just specifically now we're talking about skilled nursing. So that's wild. That's wild. Like, that's wild. That's wild that you have to hope that there's an accordance in that implementation. And that becomes the fate or benefit or whatever of that patient who doesn't even have someone to advocate. Because you're assuming the facility's doing it. Some are, don't get me wrong. Some are great. Some are doing it. Most are not. And we haven't even dove into the independent space yet, which of course is completely up to the resident to determine their health care needs and decisions and all that. But wait till we talk about assisted living facilities. Woo! Woo, a little step down from the skilled nursing, which is highly regulated by our CMS Medicare guidelines. When we talk about assisted living, we got state regulations. My God, it could be, you don't know what you're going to get. Okay. So knowing that, and again, we're still talking about a marginal percentage of people that are over 65 that actually live in these settings. Most people are living at home. Okay. Again, so I've just given you guys multiple avenues of why there's always a demand for deprescribing experts and these concierge approaches to reducing harm in this population. But who is doing this for the people in the community? I'll wait. I mean, frankly, we just end up hoping that this is what's being done when you go to your primary care provider. We're hoping. Does it always happen? No. Are most of these providers trained in geriatric medicine? Hell no. So we're basically putting the future of healthcare on, for the most part, because the health system is just going this way, and it's no slight to them, but NPs and PAs, some geriatric trained, a lot won't be. And so they're going to be the ones now who have to make these decisions. And you have to hope that that process is being holistically reviewed systemically. And it's hard for anyone, no matter mid-level to, I don't care. It's hard for any primary care provider to sit down for an hour and just talk about the meds. It is damn near impossible. It's not embedded in the system. There are some unique places that do that. I know Oak Street Health was very big on dedicating an hour. I know Centerwell, I believe, does that with the Humana outpatient centers, health centers. Some places do that. Okay, I'm not talking about that. I'm talking about across the board. Are you able to truly sit down for an hour and go over each and every single med, every dose, every side effect, Are you able to go over genetics? Are you able to look for inappropriate meds? Have you considered tapering schedules, drug holidays? Have you even assessed the vitality and long-term benefit of what they're doing now versus how it may have helped them 20, 30 years ago? Or if their life expectancy is low, do they still need to be on all of them? The different angles to this, but there's so many, again, spectrums of aging where we're still missing the mark on one of the most glaring, obvious pandemics in this country, which is the overuse of inappropriate medications. Not just in elderly, but across the board. But specifically, our older adults are the ones who have the highest risk of harm from it. So yeah, that's what I'm going to harp on. So there's just, that's what I feel insurers want. That's what providers want. Patients absolutely want deprescribing. Caregivers want less is more. People want this. So why aren't we giving it to them directly? Why aren't we giving it to them? So why isn't it working? We're doing the same stuff. That's really why. We're doing the same stuff over and over again. For a not very friendly aging population in terms of the health system. The health system isn't very age friendly. In fact, medical literature isn't very age friendly. I mean, a lot of it's based on middle-aged white men. In terms of our guidelines and drug therapies are usually, even the way we design houses, and I learned this recently, the way we design damn near all houses were based on like 1950s demographics of 20 to 40-year-old white males. It's not meant for your person in a wheelchair or your grandma who can't read. Like the way we design the layouts of these buildings are old and archaic. So again, there's just a lot of things aging friendly wise we may be missing. But it doesn't mean that it's all gloom and gloom. We just got to change the way we do business. That's all. But we're not doing it because, well, it's novel. We're very quick to say we don't have time. As you know, there is indeed a staffing labor shortage in anything older adult. So you're going to have time, capacity. Most people don't realize that there is a framework that you can just implement into your general day-to-day processes. So you may try a little bit or you may talk, but they don't do. And then of course you may even balk at the lack of reimbursement for that, right? At least in terms of a billable, code to get reimbursed for making an intervention around deprescribing. And there are ways around that. I'm not talking about that, but the truth is, some of these retirement communities, these aging service providers, they don't realize that they can seamlessly partner with a pharmacist or even just an expert who's clinically trained around older adults and med management, and can do this by just building out a system, by talking about the problem, by checking and tracking your outcome, by talking about the problem, by building a case, evidence-based case on why this isn't working and personalizing it to each family you meet. And doing that in a way that's collegial, friendly, and meant to take off the plate of the providers who are inundated with seeing 16, 20 patients a day. Okay? We are here to work with your providers. We are not here to start conflicts. We're here to make their life easy by making your problems go away, by identifying which of these high-risk meds or interactions or disease drug interactions are what's presenting today. And if we can help figure that out, that's at no cost to your provider. My God, we will make life so much easier for more and more patients. And that makes providers happy. straight up. So I think that's the fear some, I would say, entrepreneurial pharmacists have in getting into this concierge space, is that they think that they can't do this because it won't be received. And it's like, we've got facts that there is a problem. We've got facts that people want this. We've got facts that providers want this. They just don't know how to necessarily do this. And so having that extra eye at free of charge of them is a blessing. And at the end of the day, the insurance wants this too. They just haven't found out yet how to make it monetizable. Or they have it in very archaic models that I just cannot ascribe myself to. But hey, it works. It doesn't mean you can't do it. It's just not me. So the counterintuitive thing people got to start doing is embedding deprescribing experts into your care processes. And let them be the guide, all right? All of you in these touch points of working with clients or caregivers, in some way, shape, or form, you're collecting data. Look, I go to a doctor's office, I'm filling out a form that's 10 pages long with different releases, your medical history. You're doing all that. You're putting your drugs, you're putting what you're taking, your allergies. In some way, shape, or form, you are doing some type of data collection. There is nothing wrong with putting 3 to 5 questions that are literally meant to broach a deprescribing conversation. We've got tons of frameworks, guys. I mean, I think there's the SAFE framework, there's Vione, there's Stop Start, there's Stop Fall. I mean, there are tons more. Drug burden index. There's so many explicit tools that you can potentially use. What I find most helpful is simply having an eye-to-eye and asking them, how do you really feel about all these meds? What's helping you? What do you most have an attachment to? What do you feel is bothering you? Do you have issues with any of them? Have you ever experienced boom, 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 boom? Just start with that. Start with that and, pose, maybe the time for this med is up, and then lead that to, again, talk to the provider about potentially tapering. We're not going to tell people to just stop stuff. It's counterintuitive and it's not safe. And nobody wants a lawsuit in this day and age. So the aging industry wants this. The people want this. Providers want this. And it's not easy. And I say that from the angle of, you're going to have to go over the medication mindset that I have to be on this forever. So we're going to have to, one, rewire your brain. This is what I mean by the matrix of thinking that this is the only way I can heal. So you're going to go against that subconscious barrier of, well, I've been told this all my life. There's no way I can stop this. You're going to face that. And that's cool. I mean, that's part of the process. So you got to rewire that train of thinking, the medication mindset, I call it, or shift that medication mindset. So that's one. Two, you got to make people aware that, apart from shifting the mindset, you got to make people aware that you can also heal by deprescribing. You can also see deprescribing as a medical intervention or a treatment, not as I'm abandoning you or I'm giving up on your health or something like that nature. So you have to address some of those psychological pieces too. But yeah, so I mentioned medication mindset. So unplugging the matrix, building that awareness, having experts, first of all, trained in what deprescribing is, how to implement it, how to oversee it, how to start the process, how to have empathy-based care. You're going to need people who know how to do that. And that is going to take a niche level of service and training to understand that. And we've got awesome consortiums that are a wealth of resources. So again, check out deprescribing.org. They've got tons of guidelines around that. Check out the US Deprescribing Research Network. They have deprescribing research networks across the world. Australia, Europe, we've got different names and acronyms, but they're all over. Canadian Deprescribing Research, awesome. You've got so much free, awesome, accessible content and algorithms and maps. It doesn't have to be as hard as you think it has to be. Just to pose a conversation. They've got video training modules on how to do this. They've got resources for you on how to just drive a positive convo. It doesn't, again, require a rocket scientist. So you need people who actually know what the hell they're talking about. And people that are doing it in a safe and personalized way. And then four, you gotta monitor the shit. You gotta track what the hell you're doing. And you gotta, track how many people are having positive conversations about this. Track how many people are having a one or two meds possibly stopped, or maybe an herbal or OTC or something stopped, or a symptom that's resolved as of stopping in something. You just gotta start. And these frameworks start with having one cultural shift in an organizational cultural shift. There has to be buy-in from this. There needs to be support. There needs to be a little bit of funding. Yeah, you got to reimburse and reward people for doing this type of stuff, because it is a shift in an entire system and ways of thinking from the provider back end to the patient back end. This requires a lot of shifting. However, is it doable? Absolutely. We've got tons of interventions where people have done this with mailers, with phone calls, with advertising on the radio, with partnerships with providers and nurses and technicians. We've got so much literature that tells us that this can be done and is being done across the world. So it's not impossible. We're just slow to take action in medicine. That's all. So it is happening. That's why there is a movement to more holistic health and alternative healing. That's people want more of that. People want their genetics tested to see if there's any drug interactions with that. People want their biomes checked out, see what my gut microbiome is doing. There are so many avenues. So the aging industry wants this. People just haven't necessarily realized that there's a way that you can provide this and you can get paid to do this. This is a high-level service. Anything that's a high-level service can command a high-level price. That's just business. And that's where I think clinicians don't realize you can absolutely charge for this, and you can get paid for this, and you can build a clientele of people who benefit from this. Absolutely. That's why I'm still here. So the counterintuitive thing is to do something different. I know. It's scary. I know. I get it. But work with people who advocate for this. Embed them into your practice. Give them 15 minutes of their time to work with people. Better yet, if you have a provider on staff or a medical director or DON, have them all part of the conversation and let this be a new cultural shift. And yeah, you're going to meet, you're going to have barriers, you're going to have discussions. And that's the best part, is that's where the change takes place. And that's where the conversation leads to organizational changes. So it is going to take having, in my eyes, policy change. It's going to take a cultural change. It's going to take a bit of a financial reimbursement or a way for people to monetize deprescribing within the aging industry across all spectrums. And so you're going to need key niche people who study and specialize in deprescribing and put them into your worlds of genius. All right. So they want it. People want this. People want it. Systems want it. We've just got to do it. So I'm hopefully giving you guys a framework on how you can embed yourself if you're listening, if you have a passion for this. This is what I've had the pleasure of navigating for these last 5-6 years in starting geriatrics and creating the Deprescribing Accelerator solely to train clinicians on how to do this, on how to implement themselves and integrate with other aging service providers to bring a high value service that the system wants, but isn't ready to handle it yet. So I hope this was helpful. This is the future of aging. This is what we need to address today, because we're already in the overprescribing crisis today. We need that to just provide the quality care that our older adults deserve. That's what we need to do. So appreciate you guys tuning in. If you want to learn more, comment Red Pill. You'll learn more about our Deprescribing Accelerator, how you can get involved, join the movement, and we'll set up a call and see if you qualify. But I hope this was helpful. How the aging industry wants deprescribing, but they don't know how to give it. If this resonated with you, have that conversation. We talked about building your team around the aging roadmap. So I want you to, if you haven't had that tough convo about what you want to do with mom and dad, or even yourself, talk to an elder care attorney, knock out that will, create a plan today when you're not in crisis. All right. And now, and of course, if you need someone to review those meds, that's what we do. We love doing it. We're happy to do that all virtually, help you out and give you some next steps and peace of mind on if that's the best fit for you. All right. I'm Dr. DeLon Canterbury, the Deprescribing Pharmacist, founder of GeriatRx and the Deprescribing Accelerator. Thank you all for tuning in. We'll catch you guys later on next week. Take care.